How long have you been using Dilapan S in your practice?
Since 2018.
Okay. And just briefly, do you mind taking us through the process of what that insertion and removal looks like for you and that experience for your patients?
So the best part of the Dilapan is that it's non-pharmacological. The fact that it doesn't have any medication in it makes it makes the patient more comfortable with the idea. The fact that when it absorbs fluid and it expands, and the cervical dilatation, that their own prostaglandins are released, makes it, more acceptable. So they feel like, this thing is kind of working with their body, to get their cervix to where it needs to be. The insertion, typically when patient comes in, um, most of the insertions I'm doing now, when I first started, most of my insertions were in the office. But most of the insertions that I'm doing now are actually at the hospital. The I have the usually the tech is who has everything laid out. So I have a lighted speculum because visualization is key. Because if it goes in the wrong place, then it's not going to work. So, lighted speculum. I have two sponge sticks. I have we have a pack of like gauze. It's 10 4x4. That I will dump like betadine, make sure the patient doesn't have any allergies into it. So and then the other thing is sterile pair of gloves and gel. That's about it. So patient, of course, we would have had the talk in the office. Then I will explain more, ask them if they have any questions. Then while she's in the lithotomy position, we have like a spray betadine, which I would, open and dump some of that into the gauze. Um, but I usually will spray on the outside, then put in the speculum, and then fold up the gauze into the sponge tip, and then clean the cervix. I will use the second sponge stick to hold the anterior aspect of the cervix at 12 o'clock and then insert each, But when I insert, I don't push in, I wiggle. And I found that that just happened one day, and I found that that is much easier, being that the pregnant cervix is, is definitely softer than non-pregnant. And then it kind of gives, as you wiggle a little bit and put that in. Once I get two um, Dilapan devices in, I usually try and put the third one in between the two, kind of splitting it. And that's what I keep doing. And that helps me also make sure that I'm putting it into the os. And where the patient is multiparous, sometimes the vaginal walls might obscure a little bit. I always make sure that I go all around, like with the second sponge stick, kind of lift and make sure I can see cervical tissue underneath that. So, and then the last thing that I do, so even though I know they've said it is not necessary to put in a sponge, like a 4x4, to hold everything up, I've always done it like that. And I still do it like that. The other reason for my wanting to do that is because sometimes you do have a little bit of bleeding, and that helps soak up everything and just, keep it to where the patient is not like overly concerned that, I'm bleeding, after the procedure. And then while I'm using the sponge stick I was using to load the Dilapan, while I'm holding on to that, I will push it on the sponge as I'm removing the speculum to make sure my sponge and Dilapan stays up in there. And that's about it.
That's awesome. Now, do you normally do the removal yourself, or or do the nurses usually do a removal when the patient comes back in and checks the cervix?
So because my patients go home and they come back in the morning, I'm going to round on them anyway. So I usually will do it. And if the except they come in labor, which is not the usual thing, usually they will come in the next morning. And because I have to round on the patient and and examine anyway, so I usually end up being the one that will remove those.
Awesome. Thank you. Really, other physicians and providers, please go ahead and type in your questions into the chat box. This whole meeting is a benefit for peer-to-peer for you guys to have those discussions. So I certainly can fill any void space, but I really would like the floor to be open for all of you. All right, it looks like someone is typing, so I'm just gonna go ahead and give that a minute. Dr. Alvarez says, why are you now doing less in the office and more in the hospital?
So yes, so it's for billing purposes. So at the time I did it in the office, it's not like I'm even doing less and less. I hardly ever do it in the office. When At the time when I started using Gillipan, I didn't have my own practice, and the practice I worked with was owned by the hospital. So somehow their coders were able to bill for it. I don't know. But being in private practice now, it's really a big headache to get reimbursement. So it's just easier for me to do it in the hospital.
Yeah, and if for anybody who has further questions about that, we certainly could help with our field reimbursement managers, answer some of those ins and outs. And we're currently continuing to work at the CMS level to work on that reimbursement. Well, while we're waiting for more questions to come in, Dr. Ello, can you let us know why you like that Dalipan S, why you like using it?
Oh, because of how efficient it is. I mean, it is just so efficient and effective that, it's made my life and my patient's life much easier, and the nurses as well. Um, Looking at it from the patient's point, the patient is not there from the night before. She comes in the morning, fresh from home, for her induction. So even if that induction, which typically doesn't happen, but let's say this is a primary gravida, ends up till the next morning, they don't feel like they've been in the hospital for days, if you get my point. Versus the person that came in the evening before, because where we use the intravaginal prostaglandins, those patients typically will arrive to the hospital around like 5 p.m. That's our practice in my hospital. And that's what I used to do before. And then they'll be there all night. Now, while that night that they're spending, the baby could come off the monitor, mom is trying to sleep, she's sleeping in the hospital bed, and then she's woken up, and this and that, and this baby fell off the monitor, and the nurses come and have to, put the baby back on. So for all those reasons, it's great when the patient is just coming in and hasn't been on the blood pressure cuff all night long, fresh from home for her induction. The second part is the fact that the amount of change in the dilatation, in the effacement, in the softness of the cervix is so marked versus doing a prostaglandin or doing the balloons and stuff, which all of those I've used before. I mean, like I used to use in the past. That's from my point. It's great for me to remove this and say you're so many centimeters. So I usually will tell my patients the minimum they're going to be is 4, and I can, proudly say that, even if they are like half a centimeter. If it's a long firm on a face cervix, then I'll probably get about 3.5 centimeters. And I usually do mine close to 24 hours. They said, you can do it 12 to 24, but I go for gold. I do it closer to 24 hours. And I get the best results from that. And it works out because when I'm rounding in the morning, I put it in, and then the next morning I'm rounding again, I remove it. So, it works for me that way. And then for even for the family, and the patient, everybody's so encouraged when you're removing and you say, she's 4, she's 5, she's 6. Sometimes they're like 7. So it's great. I mean, the nurse is happy. They're not chasing, I know this is a day shift nurse, but even then, having a patient who is kind of, advanced, and they don't feel like, oh, I'm going to be with this patient all day before she delivers. So it's great for everybody all around. So I saw that question, Fash. What did I use before Dilopan?
Yep, absolutely. Yeah, so we had 2 questions come in. So Dr. Alvarez, if your question hasn't been answered, it was, do you send them home from the hospital after insertion or keep them inpatient? You definitely alluded to them coming back in. So I don't know if you want to add anything else to that.
No, the only time I will keep them is if there's a medical issue, like if there's severe preeclampsia. And then, of course, if there's severe preeclampsia, I will wait like 12 to 14 hours. Those are not the ones I will wait closer to 24 hours on. I had someone actually that I'm inducing this morning, today, and I left it in for about 13, 14 hours. Her baby had an abnormal biophysical profile. So, of course, for her, I have to keep her in the hospital. So, but if it's something like gestational diabetes, if it's something like even pre-gestational diabetes, that is controlled, but we're just scheduling induction because, that's what we need to do. And the baby does not require continuous monitoring, or the mom, like in the case of preeclampsia, they go home and they come back the next morning. So it's only where we need to monitor the mom, and baby, like in severe preeclampsia, or where there's a concern, like the patient I told you had an abnormal biophysical profile, then I will keep them in the hospital.
Do you monitor your patients as far as like, even if you're sending them home, do you feel like you need to do that monitoring that's necessary before you send them home?
Before I send them, oh, you mean at the hospital?
Yeah, I'm sorry if I wasn't clear on that one.
Right. Okay. So the thing is, because it's a hospital setting, we went round and round and round, and then risk management said a 20-minute strip, and I said, you know what, the truth of the whole matter is, in the time the stuff is set up and blah blah blah, it's already 20 minutes, so we do a 20-minute strip, not kind of during, so like before, during, after is about 20 minutes. So we just do, and just to satisfy that, because it's at the hospital. But I put tons and tons in, like I told you, when I worked with the hospitals group, in the office without any monitoring. And by monitoring, you mean a non-stress test, correct?
Yes, ma'am. Yes. Yep.
Okay. So with the not, because the rationale for me is this. In the office, when we sweep the patient's membranes, we go far deeper in sweeping membranes. And we all do that in the office without any NST. So the Dilopan is just being loaded within the cervix. So I've never really felt a need to, have an NST for that. But being that I'm doing it in the hospital, I have to abide by the hospital's rules.
Yeah. And how many patients would you say, as a guest or on average, that maybe you've done since 2018?
Oh, it's definitely hundreds.
Oh.
I really want to sit down and, actually look at that number. But actually, since I started my own practice, I probably do at least somewhere between 10 to 20 a month.
That's awesome. And one of the questions, let's get back to that chat box. What did you use prior to Dilopan?
I used the intravaginal prostaglandin. And sometimes you will do that, you come back the next morning and patient has not changed, but they've cramped all night and there's no cervical change. That's another thing about the Dilopan, that I'm not concerned about the status of the baby because it doesn't have any medication in it. Then typically at that time, so if that doesn't work, we'll either give Pitocin all day and then give another Cervidil at night, or if it's to where I can get a double balloon catheter in, then I will do that.
Do you ever give something for pain during insertion?
So the whatever is a strong word. So I've had, maybe in all these years, 3 patients that were like, oh, it hurt. And, we gave them a gram of Tylenol PO before they left and they were fine. But otherwise, no.
And I know you've mentioned before when you've spoken with us, and that's just part of your counseling, correct? Like, kind of what to expect, what the procedure is going to be like. And so you've had a lot of success. Is that correct with your patients and their comfort level?
Yes. So, I tell them that the worst is the pressure. I don't use the word pain, I use the word pressure. And that's the truth on the speculum, because once that's out and you're done, I don't tell them about the whole thing. My words will be, I'm not going to say I'm going to clamp your cervix. So I'll be like, I'm just going to hold your cervix really lightly, as I put in the Dilapan, but it's going to be really fast, and I always have everything already ready. So before I put that sponge holding forceps on the anterior lip of the cervix at 12 o'clock, I usually use 5 every time. That's another thing I do. I know they said 3 to 5, but I use 5 every single time. Even if that os is closed, I use 5 every time. So the other thing when we're talking about what I do in terms of procedure is that I examine the patient first to determine the length of the Dilapan I'm going to use, because there's a 55 millimeters and there's a 65 millimeter length. Except for a patient whose cervix is already kind of like, I already know I'm going to use the 55, then I don't need to examine her again. If I've examined her very recently, that is. Otherwise, I also want to know what the dilatation is starting.
Yeah, awesome. That's great. What is your C-section rate following Dilapan?
So my C-section rate had always been very low. My C-section rate is, at one time it was like 6%, then like 10%, like talking about primary C-section rate now.
That would be my guess. And please, Dr. Nguyen, let us know if that is not what you're referring to, if we're referring to the NTSV rates.
Yeah, that's what I'm referring to.
Okay, perfect. Thank you.
Yeah, so I think the highest I ever got to was like 12 or 13%. But otherwise, I'm either single digits or like 10%. Like over the years, I've been at the same hospital for 12 years. So I'm trying to think of all the times, because when we do like a perinatal meeting and stuff, they review that with us. So just over the years, I think what the Dilapan has really done for me is really shorten the time as well, from the total time for induction of labor, especially, I want to say, especially with multiples. Just this week, I've had 2 multiples deliver in less than 6 hours, because one was like 6.5 and the other one was like 7 centimeters.
That is awesome. That's really, that's something to celebrate right there. That's amazing.
Mm-hmm.
What is your cutoff for effacement? Like at what point, like at what effacement would you no longer consider Dilapan for use? I think is what the question is asking.
70%.
About 70%. Okay.
Mm-hmm. And for dilatation, 3 centimeters.
Yeah, that's awesome. Tell me what, if you wouldn't mind, like what's the feedback that you've been getting from patients?
Oh my goodness, they love it. They really do. Even the ones that were like so scared, I'm like, are you a believer now? Like the lady that delivered, she delivered like in 4 to 5 hours. And she was like 7 when she came in. She was like, no, unbelievable. I'm like, yep, and it was just, you can even see the relief, um, on their faces, knowing that, okay, I've come into being induced. Because a lot of women, especially like first-time moms, hear a lot of bad stories, and they almost equate induction with, I'm going to get a C-section. So just to know that they're that much further along. And then the other thing I tell them, especially first-time moms, is that don't get fixated on the dilatation. So in the next 4 hours, if you're still that 4 centimeters, your cervix probably got softer, it got shorter, just to kind of prepare them, because I always remind them, your body didn't do this. The Dilapan did this for you. So sometimes some people need a longer amount of time for the catch up, for the body to catch up to the fact that it's, for the cervix to catch up to the fact that it's being induced. The other thing I tell them too, say a lot of times when I've removed the Dilapan, it is like so soft and stretchy that when you go, you might be like a centimeter off by the time the cervix phases and is, and the baby's head is like right on that cervix. So I always tell them, you might lose half or 1 centimeter later when your body catches up. It happens.
Do you have like a high percentage of patients that come back in, like after you place the Dilapan, if you send them home and they're scheduled for 24 hours to come back in, do you have a high percentage of patients that come back in before that 24 hours?
Oh, before 24? No, it's not a high percentage. Like
Okay.
a lot of them that would even have like cramping. So your question really is, do a lot of people come back in labor, or is it for the pain, or just come back for whatever reason?
I guess both. Like maybe if we can talk through both of them. Like, do they come back
Okay.
in for reasons that are not labor, or
No.
and also are patients coming back in labor?
The majority of patients will come back in the next morning. I've never really had anyone come back in earlier that didn't either spontaneously rupture or was contracting.
Okay.
Yeah, that's pretty
Yeah.
rare to come back in just because they're uncomfortable. It's very comfortable is what I hear. And then I
Oh,
always
that's
like
great.
to ask them, did you have a good night's sleep? Most people will say yes. And for the others that say no, they'll be like, it was really my mind. I was very anxious about today, not because I was
Yeah.
in a lot of pain. There are very few that will be like, in a lot of pain from, from the insertion.
Dr. Allo, is there anything that you really like want to close with as far as to your peers on the call here?
If for whatever reason, honestly, for the benefit to the physician, not having a patient who is there, and who is like ruptured, and you're waiting, and now they're calling you that patient is having fever and this and that, it really, really works. I mean, I feel like you just have to try it and do it. I would have loved if the physicians told me why they're not using it. Like, I have a few physicians in our hospital that don't use it. And my my reason is why, because, and it's almost like I'm showing off. So they will write, we have like a whiteboard on labor and delivery. They will write the nurse's name next to the physician's name, then the situation, and then how dilated the patient is. And then you see nurse's name, you see my name, Aloe, then you see Dilapan, and you see 6 centimeters in the morning. And then you see somebody else whose patient has been there from the night before, like 1 or 2 centimeters. And I'm like, and sometimes it's 0. And I'm like, this is a no-brainer, but I don't know. I feel like if they could maybe just organize their schedule a little bit, maybe because they have to put it in is the handicap. We're working on them. The nurses love
Yeah.
it. The patients love it. The ones that I've used it before, having their second babies with me, they can't even remember the name. They're like, that theme that you put up in there, I wanted it again.
Well, that's so awesome to hear. I mean, especially hearing that patients are requesting it and their experience is so positive.
You're very welcome.
Thank you so much. Everybody have a great day.
You as well.
Thank you.
Take care.